Now, the DASH eating plan or the DASH diet is a diet that was specifically designed to treat and reduce the risk of hypertension. It's a diet that has plenty of grains and vegetables and fruits. It also contains low-fat or fat-free dairy products, meats, poultry, and fish, nuts, seeds, dried beans, and peas, 2 to 3 servings of fats and oils, and 5 or fewer servings of sweets per week. Now, a quote from that paper I think is very interesting. So the diet design goals were to create patterns that would have the blood pressure lowering benefits of a vegetarian diet, yet contain enough animal products to make them palatable to non-vegetarians. It's an interesting admission by the authors of the paper. So are there alternatives to treat high blood pressure? And I would say, yes, there definitely are. There are yoga, Tai Chi, Qigong, and meditation definitely can lower blood pressure. There are certain supplements that can lower blood pressure as well that will have a small impact. So high doses of omega-3 fatty acids, coenzyme Q10, L-arginine, hibiscus tea, and ground flax seeds. But you got to eat a lot of flax seeds to lower your blood pressure. Omega-3 fatty acids in high doses, they do lower the blood pressure, but they also can increase risk of atrial fibrillation. So there should definitely be some caution before deciding to consume large quantities of omega-3s if just looking to lower the blood pressure. Now, medications for blood pressure, because ultimately people may need medication for their blood pressure. Now, medicine is never a forever thing. I tell all my patients who I put on blood pressure medication that if you make lifestyle changes or something changes over time, the blood pressure naturally comes down. We reevaluate the medicines. We may cut them back. We may cut them out. And to be clear, I do have many plant-based diet patients who are on excellent diets who, in spite of their best diet, their best lifestyle, do benefit from and need medication to lower their blood pressure to adequate numbers. So it is never a failure on the part of a person if they need medicine to lower their blood pressure in order to be healthy. Now, first-line choices for blood pressure medications include what we call thiazide diuretics, including hydrochlorothiazide, chlorthalidone, or indapamine, ARB agents, ACE inhibitors, or calcium channel blockers. Now, beyond that, beta blockers can be used if there is an underlying issue such as coronary artery disease, an arrhythmia, or congestive heart failure. There's another medication called spironolactone, which is a good blood pressure medication as well that is good as an add-on. Now, my strategy with controlling blood pressure is I'll start with one medication or a low-dose combination of medicines. Over time, if the blood pressure is not under control, while continuing to emphasize healthy lifestyle, I will gradually increase the dose and potentially add on medicine until the blood pressure is controlled. It's a slow step-by-step process because the last thing I want to do is to lower the blood pressure too much and cause problems and falling and passing out and things of that sort. Now, one medicine alone very rarely will control blood pressure. The average person with high blood pressure is actually on 3 medicines if they need medicine for blood pressure. Medicines are to be taken daily. They're not to be taken on an as-needed basis. Taking blood pressure medicine as needed does not reduce risk of heart disease. It just causes the blood pressure to be more labile. The goal of blood pressure with treatment is to get the blood pressure in most under 130/80, not to get the blood pressure down to 120/80, which would be a normal in somebody who's not on medicines. But also to clarify goals for blood pressure, people who are older, we definitely don't lower the blood pressure to 130/80 because as people get older, it's thought that they may actually need a little bit more pressure to the brain. So why might blood pressure not be controlled in somebody who's on medication? Could be because they're not taking their medication properly or not taking their medicines every day. Could be their diet. They may be eating a lot of restaurant food. There could be pain, anxiety, stress, all of which can drive the blood pressure up. Sleep apnea, which is a condition in which the oxygen levels drop dangerously low at night and cause changes to the arteries and blood pressure during the day. Sleep apnea is a big cause behind a lot of uncontrolled high blood pressure. Alcohol consumption, excessive alcohol raises blood pressure. Changes in weight or weight gain drives the blood pressure. Another thing that I've noted is overzealous blood pressure checking. So there's the person who checks their blood pressure and sees that it's high, and then 5 minutes later, let me see if my blood pressure's come down. Check their blood pressure again. It's still high. And then check it again. It's still high. And they're going to work themselves up into this frenzy. So how I get my patients' blood pressures under control. I like to set realistic expectations for my patients that it's not going to be overnight. It's going to take some time to get the blood pressure under control. I make sure that my patients bring me readings from home. I check that their blood pressure cuff is accurate. I make sure that the list of medicines that they bring me is accurate. I never trust what the pharmacy says they're taking or what their primary care doctor says they're taking. I want to know from the source, from the patient, what they are actually taking for blood pressure. I like to assess for whether patients are actually taking the medicines, if they're having any side effects from the medicines. I may gradually increase the doses of medication if the blood pressure is not under control. I always talk about lifestyle at every visit when we're talking about blood pressure control, because lifestyle is an important part of controlling blood pressure. I also encourage communication between visits if problems arise, and make sure my patients know they can call me, they can email me to let me know that something is working, something's not working, or the blood pressures are suddenly higher than what they were previously. Next, I want to talk a little bit about cholesterol, because cholesterol is an important thing. Cholesterol is a waxy substance that our body needs in order to function properly. We need it for our nerves to work. We need it for our brain to work. And our body makes all the cholesterol that we need. We don't need to eat anything to get more cholesterol into our body makes. Sources of cholesterol is what our liver makes, and dietary cholesterol or animal foods. Cholesterol is carried throughout the bloodstream by what we call lipoproteins. So there's LDL, which is the so-called bad cholesterol, but it's not actually cholesterol. It is a lipoprotein that carries cholesterol. And what the LDL lipoproteins do is they transport cholesterol from the liver to the cells. And in particular, when they transport cholesterol to the arteries, it can increase plaque buildup and ultimately plaque rupture, heart attack, stroke, and that whole cascade. HDL, or high density lipoproteins, basically does the opposite. It carries cholesterol back to the liver to be broken down and removed from the body. Now, it is important to know that the higher the cholesterol level, the higher the lifetime risk of coronary disease. So if you have a cholesterol that's under 200, your risk for heart disease is going to be lower than those who have cholesterols that are higher. In this particular, these are total cholesterol levels that the study is looking at. Now, the EPIC study looked at total cholesterols based on diet. So the more plant-based the diet, the lower the cholesterol levels were. So meat eaters tended to have an average cholesterol level of 204, fish eaters, those are pescatarians, 196, vegetarians, an average cholesterol of 188, and vegans, an average total cholesterol of 170. Plant-based diets definitely lower cholesterol. This was an analysis that was done in 2009. This looked at a number of studies, particularly studies that had a plant-based group versus a control group as a comparator. And if you look at there's the number 0 at the bottom, and to the left, that is a difference or lowering. To the right, that is a raising or higher. So across the board, total cholesterol and LDL cholesterol were lower in plant-based diet groups compared to the control groups with the animal products. Interestingly, the HDL cholesterol or HDL lipoprotein levels in some groups, they dropped, in others they went up. And in general, HDL cholesterol is for the most part genetically determined. There's not a lot that we can do to substantially raise HDL cholesterol. one of my patients is a woman who's 53 years old. And this is what happened with her cholesterol. She was 53 years old, had high cholesterol. She had no other cardiac risk factors. She's somebody who was interested in plant-based diet, and she took it on head first and adopted a healthy plant-based diet. Her total cholesterol went from 252 down to 192. Her LDL cholesterol dropped from 164 down to 106. And then looking 2 years later, she sustained those drops. Total cholesterol is 187, LDL was 100. So this is somebody who, with a plant-based diet alone, was able to lower her very high cholesterol levels. Now, medicines also can lower cholesterol and reduce events. So this up here, this is called secondary prevention. So these are people who have already had disease, they've already had heart attacks and strokes. When we look at their LDL cholesterol on the x-axis versus event rate, the higher the cholesterol, the higher the event rate. Oops. The higher the event rate, the lower the cholesterol, the lower the event rate. And similarly, primary prevention. So primary prevention, those are people who have not had heart attacks or strokes. There is a similar linear relationship, but it's not quite as steep because people who have not had an event yet are lower risk people. But nonetheless, several trials have demonstrated that lower cholesterol, lower event rate. So let's talk about statins. Statins are a type of cholesterol medicine. They are the most prevalent type of cholesterol lowering medication. They're also called HMG-CoA reductase inhibitors. What they do is they block production of cholesterol by the liver. They can stabilize and they can reduce plaque burden in the arteries, and they can and do reduce the risk of heart attack and stroke. Who should be on a statin medicine for secondary prevention? And it would be argued that just about anybody who can tolerate a statin medicine who has had a cardiac event should be on a statin. So people who've had a heart attack or a stroke, or a history of angina or heart-related chest pain, anyone with a history of a prior stent or a bypass surgery of the heart, and anybody with peripheral vascular disease should be on a statin. Now, what about primary prevention? Now, that's an area that's a little bit more gray, and whether or not somebody should be on a statin or cholesterol-lowering medication really depends on what their risk is. So our societies recommend that any diabetic over the age of 40 should be on a statin. Anybody with an LDL cholesterol over 190 should be on a statin. And when we see LDL cholesterols that are over 190, we consider that to be familial hypercholesterolemia, because even people who have like a terrible diet and don't exercise usually don't have cholesterol that are quite that high. It's usually, if you see an LDL cholesterol that high, it's usually some sort of genetic predisposition that causes that. And unfortunately, even if that person has a pretty healthy lifestyle and diet, that high LDL cholesterol is going to increase their risk. So we recommend lowering it with statin therapy in addition to all the good lifestyle stuff. Other people, depending on their risk of developing heart disease, we may recommend a statin. One thing I like to do is I like to make it a decision, a conversation. So I don't like to necessarily tell my patients, you need a statin. We will often talk about what a person's risk is based on their gender, their age, their blood pressure, their actual cholesterol numbers. And we can usually calculate a risk. If that risk is greater than 7.5% over the course of 10 years of having a heart attack or a stroke, typically our guidelines suggest that we can recommend that that is somebody who should be on a statin medication. One thing I didn't mention here, and I really should have, is the role of a coronary calcium scan. So a coronary calcium scan is a CAT scan that can be done of the heart. It is very low in radiation, and what it does is it basically counts pixels of calcium. If you have a score of 0, then you have essentially no calcified plaque in the heart, and your risk of having a heart attack or a stroke in the next 5 years is close to zero. So a statin is not something that's going to meaningfully reduce your risk if your risk is close to zero anyways. But if you do have calcium in the arteries of your heart, if you do have a coronary calcium score that is greater than zero, in particular if your score is greater than 100, and especially if your score is greater than 400, you would be somebody who should be on a statin, because coronary calcium scores, the higher they are, the higher the risk of heart attack and stroke. And when you have a greater risk, a statin will be more potent at reducing your risk. Now, I want to talk a little bit about myths and truths about statin, because there's a lot out there that isn't necessarily accurate. So there's the myth that statins will hurt my liver. It is exceedingly rare to have an injury to the liver due to a statin. In fact, when we see liver enzymes that are abnormal, more often than not, it is something else that's causing that, not necessarily the statin. So, for example, fatty liver is a condition that's fairly prevalent that can cause elevation of liver function tests. Another myth, statin will cause muscle aches. And there's some truth to this, because muscle aches do occur in about 5 to 10% of all people taking statins. The muscle aches will typically stop with stopping the statin, and they do not cause permanent damage. In somebody who has a muscle ache on one statin, more often than not, we can switch them to a different statin and they will not have the muscle aches, or we can change the dosing. For example, there's a statin called rosuvastatin, which is long acting. Its brand name is Crestor, and it can even be dosed once every week and still have potent effects to lower the cholesterol. Another myth, statins cause diabetes. Now, the truth is that statins do slightly increase the glucose level, but it doesn't take somebody who's got a normal glucose level and turn them into a full-blown diabetic. It'll take somebody who's fasting glucose, is perhaps on the cusp, and may just kind of tip them over into the diabetic range. But that said, statins provide benefits to the whole body in terms of reducing risk of heart attack and stroke. So the benefit more often than not outweighs the risk. Myth, statins cause dementia. Now, there is no proven link between statins and dementia. There is very rarely the patient who has what is called brain fog on statin medication, and that can often be resolved by switching to a different statin. But that said, statins actually reverse plaque in the arteries, including the arteries of the brain, and can actually reduce the risk of memory problems. So more often than not, statins can actually reduce the risk of memory impairment as people get older. Another myth, Dr. Shenkman is a shill for big statin. The truth is, I have no money to be made here off of getting people to be on statins. Most statins are now generic. So I present the data. I get no financial benefit from anybody taking their atorvastatin or other statin. Now, there are medication alternatives to statins. For example, ezetimibe or Zetia, which acts on the gut. Similarly, another medicine called bempedoic acid. Now, these two medications, and even in combination, can actually have some benefit in reducing cardiovascular risks. There are injectable medications which can also lower the cholesterol. So, for example, Repatha or evolocumab, they have formulations that can be injected either every 2 weeks or every 4 weeks, or alirocumab, also known as Praluent, which can be injected every 2 weeks. And these medications, they absolutely plummet LDL cholesterol levels to pretty low levels. One newer medication is called inclisiran. It's also called Leqvio, and it's a medication that actually can be infused every 6 months, and similarly can get cholesterol levels down to very, very low levels. However, it is a newer medication, and it doesn't have any data to show that it reduces risk of heart attack or stroke at this point. But that said, given that there is a lower risk of heart attack and stroke, the lower your LDL cholesterol is, it probably will have that impact once those studies are done. Now, to wrap up, success with a plant-based diet. That's a picture of me at the Maccabi Games in Israel in 2013. I used to be an avid triathlete. I now am a mom to a toddler, so I don't quite have the time to do those things. A plant-based diet can keep your heart healthy for years to come. It's never too late to start, And a plant-based diet goes hand in hand with good medicine for long-term health. And I'm going to give a plug for my book. It is available on Amazon.com. You can connect with me on my website, Facebook, Twitter, Instagram, or if you happen to be in California, I am taking new patients. I see patients in my office. I can even see patients via telemedicine who are in the state of California, which is where I am licensed. And thank you for listening into my talk, and I will eagerly take any questions at this point.